city and have for 13, 14 years. I grew up in Texas and New Mexico, went to undergrad here at Southern Nazarene University, and then went to medical school at University of Texas in San Antonio. Went to Charlotte, North Carolina for residency, and then a little stint in Texas and back here. So I do have a rotation. Some of y'all rotate with me for ER. I've had a couple students over the last year. They've been excellent. So Brad and Mariah, you know, did real well. So today, appropriately for the weather, we're going to talk about environmental emergencies. So we're going to cover 4 things: being too cold, being too hot, drowning, and things that bite or sting. So we're going to start being cold, which is appropriate. So we're going to talk 4 different things: hypothermia, chilblains or pernio, frostbite, and trench foot. So we're going to start with hypothermia. So what is hypothermia? So hypothermia is your core temperature less than 95 degrees. Now I don't know if y'all use metric system, centigrade, Fahrenheit, go back and forth. I don't know the metric system for centigrade, so I put both up there. I think it's easier. Most people have moved to centigrade in a lot of ERs, but anyway, core temperature below 95. So what is your core temperature? So core temperature, you see, is your rectal temperature that's 99.7, or 99.6, I'm sorry, or 37 degrees centigrade. So that is what we commonly refer to as, you know, the set point in the hypothalamus. So anything below 95 is then termed hypothermia. From 95 to 99, you could think of as normal. And then measuring core temperature. Measuring core temperature is usually thought of as a rectal temperature. The issue is most thermometers, even in ER, at home, don't measure below about 93 degrees. So they're made to measure elevations in temperature. They don't do a great job of measuring low temperatures. So there are specially made thermometers, usually in the hospital, that will measure down that low. So there's 3 different kind of classes of core temperature in hypothermia: mild, moderate, severe. You know, I don't get really, I commit a lot of brain power to remembering these certain mild, moderate, severe, because one patient's symptoms may not correspond to a certain temperature. So it's more just kind of knowing generalizations. So 90 to 95 is mild, moderate 82 to 90, severe is below 82. Some people say profound is less than 75. People have survived that low of temperatures. There was a lady, she's pretty famous, she actually grew up to be a doctor. She was one of these kids that was under the ice for like 45 minutes, no pulse. I think she had the lowest body temperature of like 56 degrees, and she lived. So, but it's not common. If you get to the moderate severe temperature, the mortality is about 40%. Mild, it's much, much higher, but much, much more improved. But moderate severe is 40%. So, you know, we generate, our body makes heat through metabolism. Most of the heat of our body is made by our liver and our heart. So cellular metabolism produces their exothermic reactions, produces heat, and that's how we keep our temperature. We have a set point in our hypothalamus, and then we're able to regulate temperature by our skin and our lungs. The surface area of our lungs is incredible. It's about the size of a tennis court, so heard that. So we're able to regulate temperature through breathing and then through the surface area of our skin, which most adult men is about 2 square meters. So again, it's an incredible surface area. Today, you know, with our temperature being so cold, we usually think of hypothermia being caused by just exposure to the elements. But we have to remember there's more causes other than the environment. There's actually what our body does to cause hypothermia. So there's a list of causes of hypothermia. Does that come through? Okay. So either you increase your heat loss, you decrease heat production, there's impaired regulation, which is usually centrally. But the ones to really focus on are these. So we're going to talk about environmental that causes people to get cold. Usually alcohol is involved. Alcohol will be a common theme on each topic we talk about today. And decreased heat production is based on metabolism. So hypopituitarism, hypoadrenalism, hypothyroid, hypoglycemia, malnutrition, and extremes of age. The very young, the very old have a hard time producing heat. So that's why babies are born, they cannot regulate their temperature, put in an incubator, wrapped up, whatever. And then the other one to really worry about, impaired regulation, those are central reasons, something going on above the clavicles, dysregulation in the hypothalamus for whatever reason. Those are not real common. The other main one to think about is sepsis. Sepsis at the extremes of age. So cold babies and cold low people are not good things. You should be very concerned when you have a cold, and not even a hypothermic, technically below 95, but even a 96-degree baby. But if you get below 95 in the extremes of age, it's very concerning, and the first thing you should think of is sepsis. And if y'all have any questions, just raise your hand anytime. So people do die, like we said, 40% mortality for moderate and severe. And these are the risk factors. These are the people that die of hypothermia. So again, alcohol, homeless, psychiatric, and elderly. Those top three, a lot of times are combined, alcohol or drug use. So one of our reactions of our body when we get cold is our body is telling us, get warm, do things, put on clothes, get to a warm environment. Well, people with psychiatric illness, or they're drunk or high, don't do that. That's why you see these silver alerts, and grandma's in her duster and it's 10 degrees below, and you can't find her because she's demented, she doesn't know, so they've lost that regulation. But these are the common things when you see someone dying of hypothermia, they're usually under one of these cases. So if someone comes in, they're hypothermic, these are physical exam findings. So they kind of correspond with that same breakdown of mild, moderate, severe. What I don't have in here, and I recommend writing down, and I apologize, is regarding mental status. So mild hypothermia, again, that 90 to 95, you're going to have a normal mental status. So they may have a little bit of impaired judgment, but they should make sense. They should know who they are, where they are, aware of events. They may be tachypnic, tachycardic, and they're shivering. Cold diuresis. Cold diuresis is where when your body's response to cold is to peripherally clamp down, vasoconstrict. So what that does is force all of your fluid centrally. Increases basically the fluid going to your kidneys, you have increased urine output, you have a diuresis. Moderate hypothermia will cause altered mental status. So your temperature again is 82 to 90. Now they're getting more severe, things are starting to slow down. So you think of hypothermia, things going down across the board. Bradycardia, hypoglycemia, hypovolemia again because of that cold diuresis, CNS depression, low reflexes, may not be shivering, and paradoxical undressing. Paradoxical undressing is they get real cold, they get altered, and for some reason people take off their clothes. Don't really know why, but it does happen. The common finding in this is hunters. They'll find hunters that have been out, it's about to be deer season, and if you're out when it's really cold, they don't always have the best judgment for some reason, and they get hypothermic, and you'll find hunters stripped down naked. Severe hypothermia, basically you're unconscious. So a temperature is 75 to 82. Again, hypotension, bradycardia, starts to get arrhythmias and those temperatures, areflexia coma. So the mental status correlates a lot with the degree of hypothermia. So normal mental status, altered mental status, and unconscious. One thing to remember is when things don't make sense. What I mean by that is you'll find someone, they have certain vital signs, certain temperature, but it doesn't really go along with their degree of hypothermia with their symptoms. So if there's an inconsistency, you have to think of something else going on. So if someone comes in and their temperature is 93, 94, but yet they're unconscious. Something else is going on. Maybe it's an overdose, maybe there's head trauma, but you have to think of something else accounting for their degree of symptoms. So physical exam, when seeing someone's hypothermic, especially extremely hypothermic, the heart is very sensitive to movement. So it's not always possible to be careful when extricating somebody from a scene or from wherever, but you try to be very careful in moving the patient. Try not to jostle because you can send the heart into arrhythmias. You then try to get a core temperature as best you can. Most hospitals will have a dedicated rectal temperature that can go down below that 93 degrees. There are, I've never used an esophagus thermometer. I have used bladder. It's not as accurate because it's measuring the temperature of the urine, and that can kind of mislead you. The best is really a rectal temperature. And when someone comes in low temperature, you still do your primary survey. You're looking for signs of trauma, source of infection, other reasons why they could be hypothermic. So what labs do you get in hypothermia? So basically you kind of get your routine labs. Fasting, blood sugar, of course it's fasting, CBC, CMP, your coags, drug screen, alcohol, CK. If you don't think it's an environmental issue, you think there's something else going on, it's the old person that's hypothermic, coming to the nursing home, you get a TSH, T4, cortisol, and even in treatment, some of those people, if they remain either hypothermic or hypotensive, you then just give them a dose of cortisol, or a dose of hydrocortisone. There's a table there, kind of gives a good findings. Really, electrolytes, there's not consistent findings. Glucose can be up or down. You have to be cautious that you're not dealing with an insulin-dependent diabetic and you're missing DKA. Other things, you know, your LFTs. The main thing that you want to know about labs and hypothermia and their temperature is the hemoglobin. So like we talked about, you have that cold diuresis, you've lost all that volume, so you're basically intravascularly depleted, so it'll cause your hemoglobin to increase artificially. There's not as much plasma. So you have this artificially increased hemoglobin. So if you have a low hemoglobin, something else is going on. You get a patient, they're 90 degrees, and their hemoglobin's 6. Then something else, there's blood loss, something else is going on, or it could be chronic anemia. The EKG, ECG, everything slows down in hypothermia. So every interval, the PR, RR, QRS, QT, usually are all prolonged, plus the bradycardia. AFib is one of the most common arrhythmias you'll see, especially as rewarming. People can change if they're profoundly hypothermic, and as you rewarm, they may go through different rhythms. And then the classic findings, what's called the Osborne wave or the J wave. Here is a normal EKG. So that big one is a normal EKG. So it's always sometimes hard to know what's abnormal. You don't know what's normal. So normal. Stick. So the best leads to look at are the precordial leads. So you can see here, J point normal, 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 normal. So what you're looking for is elevation of the J point, which is that point right there. It basically gets pushed up. So this is called a J wave or an Osborne wave after the guy that found it. It does correlate to the degree of the hypothermia. So the taller the wave, usually the colder the patient. Some people have thought that if you see this, it's automatically hypothermia, but that's not the case. It is not pathognomonic for hypothermia. Cell-arachnoid hemorrhage, head injuries, bleeds can cause an Osborne wave. To that point, a lot of things on your EKG, especially the ST segment, for some reason we don't really know why, can be abnormal in central regions. So I've had people with subarachnoids or subdurals, and they can actually have a look like an acute edema. So it's one thing, you don't always get an EKG in someone that's having a subarachnoid, you don't always correlate, but if you do, you can see these ST changes. So this is one example where hypothermia causes an EKG change. This is a favorite board question, exam question. You will probably see it somewhere in your career on it.
How would you real quickly differentiate or explain to them how to make sure that you're looking at an Osborne wave, not a bundle break block? Because sometimes early on, they're going to be looking at that and say, well, that's bundle waves. Right. What are the key points that you're going to look at?
One is the leads, B2 through E5. Really should look at like B1 for bundle wrench blocks. It's a lot easier to just kind of see there. These you're going to see far lateral, like B5, B4. And you're really, that osborne wave should not get that high up to your hull. It usually does not get that high. It's, this one, this example is pretty extreme, I would tell you. That's a pretty large osborne wave. I think the temperature on that person was like 72. So it's usually not that apparent. You'll just see kind of a little bump.
And then also your clinical picture of your
Exactly.
patient, obviously.
Here's someone that's 82.4 degrees. Again, that's an 82. This is a very dramatic example. Again, these V3, V4, V5, you just kind of see that well. A lot of times they'll give you a board question. They don't give you a lot of information other than a rhythm screw or an Ekg, and they'll ask about a differential or something like that. They can even take it a step further and think about a metabolic issue. You know, like, what would you think about if I had this thyroid? Is this a sign of hypothyroidism or something along those lines? So treatment, you always start with ABCs. CPR, it's kind of controversial. ACLS is a little different in hypothermia because a lot of your drugs don't work at these temperatures. So insulin doesn't work, epi doesn't work. If you're profoundly hypothermic, even starting CPR doesn't work. So you look for the underlying condition, you look for low blood sugar, infection, hypotension, all those, but you start rewarming as quickly as possible. So rewarming techniques. Basically, it's simple, get them out of the cold, start to get them warm. That is started by blankets, increasing the temperature in the room, warm blankets, a bear hugger. Most people think it's bear, B-A-R. B-A-R, that's a picture if you've never seen one. What this is a forced warm air blanket. I've actually used these in residency because to sleep they're very nice. It's like an electric blanket, but it's just warm air. So you have that little device there that forces warm air. That little kind of blanket has a whole bunch of little holes in it. And you have to know which way it goes. But usually people with hypothermia come in, you take off whatever wet clothes they have, everything like that, and you pack them in warm blankets, the bear hugger, you wrap their head, just cover them, and crank up the temperature in the room. If they have more severe hypothermia, you start warm IV fluids. The problem with that is that you really can't give IV fluids that warm. Now you can warm them. If you've ever had an IV and gotten fluid, you think you're getting cold, even though it's room temperature. Same thing when you irrigate wounds, people think, it's so cold. It's room temperature, but it's a 20-30 degree difference. So you can warm IV fluid. The other thing you can do is heated, humidified air. That, like we said, the surface area of our lungs is so vast, so heated, humidified air helps a lot. Then you get into the much more invasive peritoneal lavage, thorax irrigation, placing bilateral chest tubes, doing a DPL, and forcing in a bunch of warm fluid. That is probably, if they're in that bad a shape, usually people will go on to bypass, ECMO, or hemodialysis. So those severe cases you see where the kids, under the ice and they are 70 degrees. Usually they put them on bypass. Nowadays, ECMO is being used a lot more. It's a lot more facilities. We use it in residency. A lot more ERs are using it now to save people immediately putting them on ECMO. If you don't know what ECMO is the extracorporeal membrane oxygenation. So it's the heart-lung machine. That's a way to really warm up someone very quickly. The other thing is that rewarming can take a long time, especially if you're not able to do a lot of these active fluids and things like that. You may be working on this person for hours and hours. Complications from rewarming. Like I said, hypotension, that cold diuresis, you have a low volume, so when you start to rewarm, you peripherally dilate, pressure could go down. They're going to be dry, fluid shifts, you're going to give them isotonic fluid, may or may not need pressors. Electrolyte changes, like I said, it's really random. There's not a distinct electrolyte change you see. Rhabdomyolysis, you will probably see that. That's just something to kind of watch and watch their kidney function. And arrhythmias. Most likely they're going to be bradycardic. We don't really treat it. We just treat to get them warm. Same thing with AFib and AFlutter. These should all get better as they get warm. Ventricular arrhythmias, if they have them when they're 70 degrees, the drugs aren't going to work. You just have to get them warm. This is the old adage, you've probably heard, no one's dead until they are warm and dead. So I've had several patients where hours and hours you work on them to get their temperature up, and you know they're not going to survive. But you cannot pronounce someone that's 80 degrees dead. The media and TV, these are the people that like wake up in the morning, you know, things like that. So, and then people are like, well, what's warm? What temperature do I have to get them to be able to pronounce them? Most people think 90 to 95. If you can get them to 90 to 95 degrees and there's still no signs of life, no rhythm, you can really kind of stop at that point. Any questions on hypothermia?
So if you're in the middle of nowhere and you don't have all of the modalities of ECMO and all of that, just don't throw the IV fluids in the microwave. People have done that. Don't do that. Your bags of IV fluids will be in where your blanket warmers are, and they'll keep them in there. Usually those places already know all that, but I know yesterday I was talking about being inventive and make sure that you're thought of everything. That's one thing you don't want to do.
All right. So the next issue with cold is what's called chilblains or pernio. This is a cold-induced erythrocyanotic skin lesion. So it's usually on kids' faces or people's hands, fingers, toes. It doesn't take extreme temperatures. It just takes a cold temperature. They will come in with kind of that middle picture. See those kind of red lesions? They think they've been bit by something. They think they have an infection. But you have to ask about cold exposure. And there's really no treatment for it. People will try creams and all kinds of things. It's don't get cold. Stay warm, don't get cold. So, not real hard. It happens in certain people we don't really understand why. They have some type of vasospasm or vasoconstriction and an exaggerated response to cold. It's pretty common in kids with the cheeks. We're trying to see that. Again, just warming them up. It can persist. Basically, those blood vessels get full of blood. They stay red for quite some time, but it usually resolves in a week or so. So frostbite. Frostbite happens in Oklahoma, believe it or not. I've seen it here. I had a guy a couple years ago. He seemed like he had normal mental function, but he had worked like 2 or 3 days straight out in the cold with his hands, and he came in with both of his hands, very severe frostbite. So frostbite, the main thing to remember is freezing of tissue. It's not just cold tissue. That's like frostbite. It's a little cold. Frostbite is actually freezing of tissue. So you actually, inside of the cell, either extracellularly or intracellularly, it freezes. The liquid part actually becomes ice. After that happens, it causes all kinds of inflammation and ischemia, and ultimately non-corrected necrosis. Now there's 2 classification systems for frostbite. Again, I don't get a whole lot into classes on these things. This first one is based on a level at which skin lesions are noted after you rewarm them. So they come in with frostbite, put them in a bucket, say their hands, and after you've rewarmed them, you kind of look to see where their cyanosis. So this system is based on where that cyanosis is, basically how far along the digit it propagated. So grade 1, there's really no cyanosis, going to be fine, your fingers are just kind of a little discolored. Grade 2, it's just the distal phalanx. So you start to rewarm them, get cyanotic against the distal phalanx, may lose the nail, not too bad. Grade 3, it gets all the way to the proximal phalanx and they can't move their finger. Grade 4, it goes all the way to the carpal or tarsal bones, and that's a very severe, and they may get amputated. If the more common classification is this traditional system, which kind of corresponds to burns. So this does not kind of the distance like on a finger, but depth of tissue. So just like burns, we've actually gone away from classifying burns as degrees. So we really have gone to just, partial thickness, full thickness. This is still a traditional system for frostbite based on the 1st through 4th degree. So a 1st degree, basically it's just central pallor. things have kind of changed, got a little light colored, people can't feel it, they've lost touch, and a little swelling. Second degree, which is that first picture of the two hands, that's a second degree. So you have those large blisters kind of at the base of the nails there. They're full of clear fluid, and there's edema. Those blisters may turn a little black over the next several days, but they're going to be fine, no skin grafting, no surgery. Third degree is you actually have hemorrhagic blisters. So kind of that second picture there, you get these blood-filled blisters. That skin's going to slough off, and that will take actually several weeks. And then fourth degree is kind of that foot. It goes all the way to muscle and bone, and you're going to lose those digits. It's not always easy to say what degree someone has when they first come in. It's obvious if they have fourth degree and they have a rotten foot. But those second and third degree, you don't really know until you start rewarming them, and it may take several days to see how they respond and kind of what happens. And everybody's different. Whatever their age, their general state of health is going to play a big part into kind of their stage. So, treatment. One of the golden rules is, if the patient has the possibility of getting cold again, don't rewarm. Only rewarm them if you're going to be able to stay warm. So this comes into play if you're going to transport somebody, usually by helicopter. So you have to fly somebody. You know, helicopters are not always really warm, especially if you already have a hypothermic patient. If you're in a cold environment, helicopters fly in a cold environment, they may freeze again. So you only want to rewarm if they're going to stay warm, because it can do more damage going from frostbite, rewarming, back to frostbite. Like I said, bulla with either clear bloody fluid may develop after thawing. Do not rub it. Don't use a stove or an oven. People will come into like a cabin, start a fire, they have frostbite, they'll put their foot there. Well, it's insensitive. They can't tell that they're burning their foot. So now they have frostbite with a burn. So it's a bad situation. The main way we rewarm people is basically hot water, a bucket. I mean, today we're not talking about technical technology, how to treat people, but it makes a huge difference. So heated water, 98, 102 degrees, you can have them kind of move their foot or fingers in there, just don't rub it, and they're going to need pain control. Because it first doesn't hurt bad. They start rewarming, it's extremely painful. Usually requires IV narcotics. You know that your thawing is complete when the tissue's red, purple, it's soft. Depending on the degree, it can take half an hour, and then it's going to turn into long-term wound care. So a lot of these people we admit, because of wound care, they may need a debridement, taking out tissue, or an amputation. Get to the point they do not get sensation back, they do not get perfusion back, and they end up with an amputation.
So they can tolerate 102 degrees in still water.
You been in a hot tub?
Yeah.
It's hotter than
I
102.
guess that's true.
So, yeah. Because I mean, they get to like 115.
When you get cold and you put your hand,
Oh, yeah.
and that hurts, but
It
you're
hurts.
fully sensate, I guess.
Yeah. But at first they don't, and then all of a sudden, and then they don't want to keep their hands in there.
Right.
And then they maybe alter, they're drunk or high, and it's just nightmare.
So why don't you,
Well, you can slough, you can do further damage, cellular damage, you can kind of crunch those cells, and it's painful. Don't punch it. It is very
you won't be
painful.
able to do it for very long.
Exactly. All right, anything on frostbite, chilblain, hernia, gut? Last thing is trench foot or immersion foot. Everybody teaches this. You don't see it real often, but it's always put in these lectures. I guess going back to the war, you can see that guy. This is not anything to do with temperature. This has to do with exposure to basically prolong some cold but really wet dampness. So you can see that guy in the trench, and that's how the guys in the war were. They stood in these trenches of water, and they didn't take their boots off for weeks and weeks and weeks. So you can imagine what your foot would look like. So On top of that, they wear tight boots, they're all wet, they're cold, so when they finally take it off, they develop trench foot. If they got secondarily infected, they call it jungle rot. They would lose toes and get infected. But basically, you just start sloughing off skin. It's kind of like if you've been in the pool for a couple hours. You kind of get the prune. Just imagine staying in the pool for like a minute. It's just going to slough off. I think I've seen this one time in a homeless guy that had not taken his shoes off in like 4 months. And it's not pleasant. So, okay, that's cold. Any questions on cold? All right. Now, we're going to move on to hot, or dementia in hot. So, exertional heat illness is kind of this term that is now used to describe this spectrum of problems. So, people don't agree on terms in this field of research for some reason. I don't know why. You would think it'd be pretty straightforward that we could all agree on certain terms, but they don't. So the research is kind of all over the place. So exertional heat illness, EHI, is kind of this term to encompass those 4 issues: heat cramps, heat syncope, heat exhaustion, heat stroke. The reason a lot of those people don't agree is because the level of the temperature doesn't always correlate with symptoms. Same thing as hypothermia, same thing with hyperthermia. So first thing we're going to talk about is heat cramps. So, and I don't hate LeBron James, but if you've watched basketball the last several years, there was a game in the playoffs at San Antonio that air conditioning broke, and literally he. But heat cramps is really a misnomer because it's never been found that heat is the main factor, although you see it in hot environments. A lot of it is because people are pushing themselves in a high intensity to the point of exhaustion. And I will say LeBron plays at that level, plays at an extreme level to exhaustion. So it is more often that's going to happen in heat, but it can happen in swimmers, it can happen in ice skaters, hockey players, they get cramps. So treatment, hydration, sodium replacement. As long as they're not vomiting, oral hydration is as effective as IV, although the elite athletes at halftime get IVs. So stretching, incredibly important. I think a lot of athletes, young athletes, do not appreciate the amount of stretching that professional athletes do. They're 1 to 2 hours before a game. And prevention, sodium loading. So there's salt losers, what we call salty sweaters. I remember in athletics, those guys that would like have salt rings around their jerseys, this wet. They're salty. They're salty sweaters. So they just happen to lose more salt than your average person. Those people really probably need to salt load. I know several of the Thunder physicians. So Russell Westbrook, before every game, he drinks this drink. And I don't remember if it's like 4 grams of sodium. It is a, he takes in just massive amounts of sodium before every game. They also tailor-make each player a shake, a recovery shake that's tailored to them. It's amazing the science that goes into it. They also have telemetry devices that they can wear that someone with an iPad can measure, his heart rate, his rhythm, his temperature in game. And so they can look at, they have algorithms that will probably produce like expected lactic acid production. And if it gets a little high, they say, hey, we can take them out, 45-second break, give them a break, and put them back in. It's, the technology that's out there is mind-boggling. Same thing with a lot of even now it's reached the college level, maybe some high schools. You've seen those temperature, the guys swallow pills, and it monitors their temperature. Because you can't really use these forehead thermometers or ear thermometers. They don't give you a great temperature of your cooler for hyperthermia. So, anyway. Next thing, heat syncope. Again, it's a misnomer. Heat does not cause the syncope. It really should be called exercise-associated collapse. There's a lot to remember. You can say you passed out in the car. You see this a lot at the end of a marathon or any type of running event. So they'll reach the finish line and they just barely and they just fall. So what happens is they can't stand, they can't go on, they probably have preceding lightheadedness, they feel it coming on. But what happens is that whole time they're running, your skeletal muscles are constricted, they're working really hard, so their systemic vascular resistance is pretty high. So it's keeping their pressure up. One, they're also dehydrated after running 26 miles. And then as soon as they get to that end, they kind of relax. Dilation, your systemic vascular resistance drops, your pressure drops, you pass out. So at the end of the marathon, it's very common. What should happen is their core temperature should be pretty normal. Maybe a little high, they may pass out, they may lose consciousness, but they should come back around pretty quickly. Their mental status, if it's prolonged, if they have altered mental status, they really need to be sent to the hospital. And you then pursue a typical symptom workup. But most of the time, these people turn around, they kind of get some fluid in them, their pressure builds back up, and they're fine. Heat exhaustion. So the next two things we're going to talk about is heat exhaustion and heat stroke. And it's routinely, these diagnoses, these terms are used incorrectly. And it drives people crazy because everybody will say, oh, Grandpa Joe had a heat stroke, or I had a heat stroke. No, you didn't. You probably did not have it because a heat stroke is actually a very serious condition. Heat exhaustion is you basically can't keep your cardiac output due to the demands of whatever you're doing in a hot environment. So these people will collapse, they can't go on. Their core temperature is actually elevated. So they actually have an elevated core temperature, but they're still normal thinking. They have a clear mental status, they can tell you what's going on, they may be tired, they may have some nausea, vomiting, diarrhea, headache, cramping, but they still are with it. They lose a lot of free water, they lose a lot of sodium, and again, the salty sweaters, it really varies on people. So this treatment, hydrate them up, and they should be fine. A lot of times you'll see them at the end of a race or whatever sport, cool them off, put them in the shade, get their feet up, put the cold towel around their neck or over their head, spray them with water, and have them start drinking. I played soccer, we used to drink pickle juice. So it was fluid, it was salt. I don't know if it worked. It felt like it took the layers. Put something on your teeth. And if they do not improve, go to the hospital. Heat stroke. So the most important thing to remember about heat stroke is that it's characterized by CNS dysfunction. So heat exhaustion, normal mentally. Heat stroke, you have some form of altered mental status. You have some form of CNS dysfunction, usually unconscious, seizure, delirium, whatever it may be. If you have elevated core temperature in the right setting with altered mental status, you have a heat stroke. What that represents is, since you have CNS dysfunction, it makes you think you may have cardiac dysfunction, renal dysfunction, liver dysfunction. So it's kind of the most prominent outward sign that this is more serious than cramp or exhaustion. A lot of these people are disoriented, they'll have a headache, confused, they may be emotional, they may be irritable, unreasonable, difficult to deal with. This is true in all of medicine, is trying to differentiate someone's personality from pathology. Sometimes their personality is pathologic, but is there an underlying condition causing them to act the way they are? Or is that just how they are? And that not only here, but in many, many conditions. And you can get yourself in trouble if you just chalk it up to, they're just an ass. Well, you better be right, because I've seen many, I review medical legal cases, and more times than not, people are wrong and have really bad consequences. So, tachycardic, hypotensive, nausea, vomiting, diarrhea, profuse sweating. So, do not think just because someone has stopped sweating that they're even worse or better. It doesn't correlate. Many, many high school coaches think this, and it kills kids. That, hey, they're still sweating, they're okay. It's when they stop sweating that you were incorrect. So, most time, heat strokes, actually, they're profusely sweating. It can get to the point that they do stop, but Do not fall into that fallacy. How do you treat heat stroke? Try to get a core temperature. Usually if you're at the end of a marathon, you're not going to get core temperature. You know, the guy's unconscious. You can tell he's hot. So rapid cooling. You have to cool them down before you transport them. So even if they're unconscious, cool them down before you transport them, because the treatment is quickly cooling them. You see that guy in that's called the tarp method, where that guy and all those people are holding that tarp. If you're in a marathon, there's probably a tarp somewhere. I mean, something on the wall, something. So basically, you just create a pool around that person. You dump ice and water, and you dunk that person in there. Of course, if they're unconscious, make sure they go underwater, put them up. But you leave them in there for 15, 20 minutes. They do this at the marathon downtown all the time. So if for some reason, pulseless or something, of course, you try to treat that. But the key is trying to get them cooled off. Ice, wet towel rotation. You see the other picture, the guy's just packed with ice. Usually you put that in the groin, axilla, head, neck, where the big blood vessels are. You try to get them cooled down to like 102, 103. A lot of times these people are 106, 107, 108. You're just trying to get them, you're not going to make them normal thermally. You're just going to cool them down to about 102. That last line, if no thermometer, cool until they shiver. So you put them in there for 20 minutes. If they start shivering, it's usually a good sign that you've got them down around 102. Once they come in, what do? Labs, kind of your typical labs, including the CK, a lactate. I'm not a big A1G person. Chest X-ray, CT head, and just kind of continue watching them. You basically continue to cool. They're going to need IV fluids. They're probably in some exertional activity. They're going to be dehydrated. You'll watch their electrolytes, mainly sodium and potassium. And then if it's severe, you'll watch for evidence of rhabdo, evidence of kidney injury, liver failure, DIC. And you watch for cardiac dysfunction, meaning they continue to stay hypotensive. So this is what's called high output cardiac failure. Most of these people are young, healthy people. Hearts are pumping like crazy, but your systemic vascular resistance is so low, they're pumping against basically no pressure. So this is key to remember, is that the severity of someone's heat illness may not really be apparent right at the beginning. They can change. So they get a little lightheaded. They can continue to increase their body temperature, increase their symptoms. So it's a matter of kind of watching them over time. And as the longer they're hot, the worse they do. Same thing with cold. The longer that person's cold, the worse they do. The longer this person stays at an elevated body temperature, the higher their morbidity and mortality. So the key is quick cooling down. This is just, I'm not going to go over it, this is basically how to treat it. This is guidelines for cold water immersion, how to kind of cool someone down, a lot more detail than what I talked about. And then this is actually very good, because this goes against a lot of myths that are propagated. And a lot of people, your relatives, people that are not in medicine, these are things they believe. And this is what we fight against. And it's very difficult, because this is like what the general population thinks, it's what's propagated, and a lot of it's not true. So, first one, athletes stop sweating when they develop exertional heat stroke. What I talked about before. Sweating has no correlation. So, they've tried to do some education over the last 10 years. Football's the big one, with coaches, trying to educate coaches on signs of heat illness and kind of what kids do. Because it was a common belief, as long as they're sweating, they're okay. And it's not true. Athletes must be severely dehydrated to develop exertional heat syndrome. Well, they don't. The dehydration may not happen. And it's not necessarily a precondition to having severe outcome. Body temperature can be accurately determined using external means. Coaches used to have ear thermometers, and at practice, like in two-a-days in the summer, it's a big deal. They would take people's temperatures, or they would use the forehead strip. It's not accurate. It tells you the temperature of the forehead. It doesn't tell you the core temperature. Lucid mental status in a patient with severe heat illness means everything is okay. Again, not true. Their mental status can change rapidly. So that's not an indication. what happens over time is more important. Shivering delays cooling. Again, that does not hold true. The onset of exertional heat stroke is unpredictable. That's not really true. That's one thing you can kind of tell. So they've tried to get athletes and coaches not to do practice. 2-a-days is a big thing. So I grew up in Texas, and football 2-a-days, I mean, it's amazing more kids than that. Because what the military looks at is a certain temperature where you're taking humidity and the temperature, and you get this formula. So Texas, in the summer, it's hot and it's humid. And when it's humid, it's really hard to get rid of heat. Plus you're in pads, helmet. These kids are not in great shape, and it is just a formula for disaster. Every year, we still have kids die. You know, the kid in Maryland just died. Coach lost his job. Big investigation. We see we can't get it right. Cold water immersion puts the patient at risk of drowning. As long as you're watching them, you shouldn't let them drown. Cold water immersion is unsanitary. It doesn't matter what the water is. As long as it's cold. I don't care if it's clean, dirty, it doesn't matter. Just put it on. Exactly. Hypothermic afterdrop can occur. So, hypothermic afterdrop is where the cool fluid, basically from your periphery, goes to your core and drops your temperature. It's not a consequence, it's this theoretical thing that people thought about for a long time. It's nothing to do with it. Ice water immersion is uncomfortable for the patient. If you are at the point you need ice water immersion, you really don't care about comfort. Just throw them in the water. So, all right, any questions on too hot? Next, we're going to do drowning. So, drowning, it is not many people realize how many people die of drowning. It's a leading cause of death in children under 5 in states with high number of beaches and pools. So, California, Florida, Arizona, even Texas, I would say us also, doesn't just take a beach or a pool. We have a ton of ponds and farm ponds and stock ponds, and that's where a lot of kids die. The highest incidence is males, African American, low socioeconomic status, and that's because they're not taught how to swim. That's the group that is more likely to get in water but not know how to swim. The second highest age group is males 15 to 25 because they're just not smart. Not right, they do stupid things, and one of the main reasons they die is they drown. In fact, there's a bad drowning this summer. Bodie Miller is an Olympic skier, great Olympic skier. His daughter died. His wife is a volleyball player. I think she was 19 months old. Lived in a nice neighborhood, had people there, found dead in the pool. Tommy Lee, one of the true fans, had been at a house party. And one of his friend's son, who was 4, face down in the pool. There's people everywhere. They had hired people to watch the kids. So that guy's going to sue Tommy Lee for a lot of money. So one of the things with drowning is, again, definition. You'll look in the lay media and you'll just see, oh, this kid died of dry drowning, delayed drowning, wet drowning, secondary drowning. Again, these stories get propagated, so there's all these myths and misinformation. So the World Health Organization, this is their definition: the process of experiencing respiratory impairment from submersion or immersion in the pool. Pretty simple. So a lot of people will say non-fatal drowning, fatal drowning. But these other terms, near drowning, dry drowning, wet drowning, secondary drowning, these are not medical terms. These are made-up terms, usually by the media, to describe, these sensational stories. So who drowns? Oh, I'm going to talk about this at the end. Just remind me. It's a way to help kids not drown. It's an organization called Infant Swim Resource. I'll show you a video at the end. My kids did it. I'm a very strong believer in it. Basically, it teaches kids, even toddlers, babies how much ground. It's phenomenal. I have 3 kids. My youngest did it when she was 9 months old. So, and I tested it. I'm not like sadistic. I'll show you. So risk factors for drowning. Of course, lack of supervision. Little kids can't swim, or guys think they have an overestimate of their ability. Risk taking, they're going to dive off something. I can swim across this lake. Of course, drug and alcohol. 50% of adults, it's involved in drowning. Usually, trauma, like having a stroke or an MI, is pretty rare. Breaking your neck and drowning is actually pretty rare. This other risk factor is hyperventilation prior to shallow dive. You'll see these people, I don't know if you've ever watched free diving. I've watched, it's amazing. But what they'll do is they'll do this hyperventilating right before they go down. Now those people are trained, their body's used to it, but some people do this. So what they do is they blow off all this CO2. Then they hold their breath, they go underwater, their oxygen falls, and the PaCO2 is supposed to rise. But since you blew it all off, you don't have the normal rise to give you the trigger to breathe. And so it takes longer for your PaCO2 to rise, and all of a sudden, you're hypoxic. You get a little goofy, you lose consciousness, you drown. So what happens when you drown? So you go underwater, all of us have an initial breath hold. That's our response. And usually you're panicked. You know, if you've ever had a near drowning experience, it's very stress-inducing. When you're underwater, you hold your breath. You know, you physically, even now, you cannot not breathe. You can't do it, even above water. So you try to hold your breath. You're eventually going to have a reflex inspiratory effort. So what can happen is either you aspirate some water or you have laryngospasm. And you still get a little bit of water in. Once you get that water into your lungs, the result is hypoxia, which then affects every other system. So the degree of hypoxia, the degree of how long you're under, how much you aspirate, determines kind of the severity. So hypoxia leads to acidosis and cardiac arrest. You can see there, aspiration of 11 mils per kilo will change your blood volume. 11 mils per kilo is a lot of fluid to aspirate. 22 mils per kilo to change your electrolytes. Yeah, that's a lot of fluid. But animal studies have shown just 2.2 mLs per kilo can affect oxygen exchange. So for an adult, that's like a cup of water. That's not much water. And it'll affect how much oxygen you can exchange. So what happens, you aspirate that water, and it produces hypoxemia because surfactant is washed out. If you don't have surfactant, you can't exchange gases. So all of a sudden, you can't exchange gases, surfactant's washed out, it produces pulmonary edema, and there's an inflammatory response that occurs in the lungs, and all of a sudden, you're not exchanging gas. This can then lead to ARDS. People get very short of breath, they get crackles, they can wheeze, very tachypnic, and it can kind of happen insidiously. So, and chest x-rays, we really don't rely on it. This is a clinical diagnosis. You just look at the patient. What's their respiratory rate? What's their work of breathing? Work of breathing should be a vital sign for pulmonary issues. I use it with kids. I dictate it on kids when they come in for respiratory complaints, because I don't care really, SAT's important, but your respiratory rate and your work of breathing. They may have a normal SAT, but if they're breathing 60 times a minute and they have retractions, that's much more important than what their SAT is. So when looking at a post-drowning victim chest x-ray, is usually not helpful, especially initially. Chest x-rays in pulmonary pathology, not only in drowning, but pneumonia, always lag behind what's happening clinically. It also lags in improvement. So you're going to look worse than your chest x-ray when you're first sick with a bad pneumonia, and your chest x-ray is going to look worse than you do after you get better. It just takes time for those changes to happen. Neurologic hypoxia, ischemia causes neuron damage, which usually causes cerebral edema. And cardiac-wise, the cardiac is affected through arrhythmias, usually from hypoxemia. Again, hypothermia plays a role in drowning, so a lot of times it's cold water drowning. And then the acidosis will produce tachypnea, And usually the kind of spectrum from acidosis in your heart as you go from bradycardic to PEA to asystole. I've seen many people I watched in ICUs, and you can just watch them, their DNRs that slowly die, and you watch their rhythm. They become bradycardic, they widen out the QRS, PEA, systole. It's all because of acidosis. The heart is not like the rest of it. So what do you do? So ventilation is the most important thing. That's why you see, like in the ocean, as soon as they get people out, they are doing breaths, bag valve, whatever, they are ventilating that person as quickly as possible. They used to get really fixated on, well, no, they have a broken neck. We need to get them in a collar. It's really, you should not delay giving breaths to put someone in a collar. Just start giving them breaths as quickly as possible. Unless there's some reason you really think they have a C-spine injury. They dove off a cliff. But really, the most important thing is ventilation. If they're unconscious and aren't able to protect their airway, intubation, a lot of days now with BiPAP, we go quickly to BiPAP. So BiPAP is a non-invasive machine. It's a big mask, goes over them, and BiPAP will kind of have an inspiratory and an expiratory setting. So when they inspire, pushes air in. And so it's helping to expand the lungs, clear the fluid, and it's very, very helpful in drowning patients. And then your trauma evaluation. Make sure there's not a secondary injury. It's just drowning. They didn't break their leg. They didn't get bit by a shark. Nothing else going on. Salt water versus fresh water doesn't matter. It's all water. Washes out the surfactant. So there's really no clinical significance. Again, chest x-ray, the findings will lag behind the clinical picture. You can see these. These are both drowning patients. The one, what's that one?
Very severe, this one. So severe, you can see ET2 sitting right there, so massive pulmonary edema. This one's a little earlier. Again, this person's intubated. They have rapid pads there, but a fluffy kind of what looks like just like cotton all through, and that's kind of what pulmonary edema looks like in drowning. You'll notice they don't have any effusions. There's no fluid. So these costophrenic angles here are very sharp. So when you get fluid in the lung, you get blunting. This will just fill up. And that's because the fluid's not outside the lungs. The fluid's inside the lung parenchyma itself. And so it'll look like pulmonary edema. And that guy's probably not going to be. Okay. Drowning. Any questions on drowning? Oh. Myths. So it says Texas boy dies from dry drowning days after swimming. This was a big story, I think it was last summer. Kid had gone with the family and went swimming, and then 7 days later he dies. And so if you search the internet and you put in like dry drowning or Texas boy dies from drowning, this story will come up everywhere because it scared parents to death. He was fine. He got a little water, but nothing really severe. We didn't even have to take him to the hospital. He looked fine, and then 7 days later he dies. And the media labeled it as this delayed drowning or dry drowning. And so I remember when this happened, we had people come in. They bring their kids in, and they're like, "And you know, kids choke on water at the pool." And they think, "Well, how do I know Johnny's not going to die? Tell me that." He's not. That kid didn't die of drowning. So he had an autopsy. He died of myocarditis. Probably totally unrelated. There's a lot of things in medicine that are true, and unrelated. And it's unfortunate that you have to do a lot of kind of backtracking and trying to correct things that are so ingrained in people. And it's incredibly frustrating. You spend a lot of your time. It's like teaching a pig to sing. You do that a lot. And it's very frustrating. And some people, they never learn how to sing and go away at it. But they're not going to die from dry drowning. All right. Things that bite or sting. This is the last bit. So bees, wasps, spiders, snakes. So no matter what you do in your career,
you're probably going to use something from today's lecture. You know, even if it's not in your line of work, you're in ortho, but your neighbor's going to come over with their kid. They got bit by this, or you're at the pool. Someone has a near drowning experience, or you're at your kid's 5K. The kid ran cross country. I'd stand at the finish line and just watch kids. It's kind of entertaining. That's terrifying. And then this. I mean, we see this every week. Either people think they're bit by the worst spider, or stung, or something, but skin lesions are so common. You really need to know what's bad and what's not bad. So first thing, bees and wasps. These are the main ones you worry about. They're all called Hymenoptera. Hymenoptera envenomation is actually, I think, the ICD-10 code. Bees, wasps, yellow jackets, hornets, and imported fire ants. So usually people don't bring you the ant. They are just nasty little boogers that cause bites that form blisters. So those are what things look like. I think everybody in the home knows what these look like. What typically happens is you get some, and that top picture with the coin shows a local reaction. So you have redness, there's kind of a painful little swelling, it lasts 1 or 2 days, you can put a cold compress on there, it goes away. People come in and they think they were bit by something awful, it's just going to get worse. Really, they just need reassurance. And put an ice pack on it, you should get better. The arm picture is a large local reaction. So some people, as you know, react more severely to getting bit. Like you may know people that are outside and mosquitoes seem to love that person, and someone else just doesn't get bit. Or they get bit and they just rub up. We don't really know why, but these large reactions happen about 10% of people. There's a gradual enlargement over a couple of days. Again, it can be like 10 centimeters. Again, it's cold compresses, some NSAIDs. Some people will do a couple days of prednisone, some steroids, but they're not infected. Don't put them on antibiotics. They're clean. Stings are not dirty. They don't need tetanus shots. They can, secondary infections, usually happen 3 to 5 days later, because it may never have been a sting to start with. It could have been cellulitis that was brewing that they thought was the bug that landed on them that bit them. So, but that's going to happen several days after. They're going to have fever, warmth, increased swelling, and yellow jackets and fire ants usually are more common cause infection. Anaphylaxis is actually very rare. So 40 people die about a year. It's 0.3% of stings, and anaphylaxis is obvious in its presentation. So here's somebody, there's a normal picture, and there's where she is having anaphylaxis. So these people will be having urticaria, itching, wheezing, facial swelling, angioedema, hives, altered mental status. The main issue is just give epi. Don't be afraid to give epi. That's the #1 cause of death in anaphylaxis is lack of giving epinephrine. People are scared because they think epi is this drug I use when people are dying in ACLS. But it saves lives. Most of the people who are having anaphylaxis are young. So the bad thing is when the wrong dose of epi is given. If you're given the right dose. I've seen it over and over. The wrong dose is given 10 times the amount is given, or 100 times the amount, and the person has a heart attack. Really, really bad to have to tell them why you're having chest pain is because you gave the wrong dose. I've had to do it. Young 35-year-old lady, and she's given the wrong dose of epi. So she starts getting better. She's having an STL dyspnea that was induced by her. So a lot of I'm sorry. She did fine.
Check the dosage. Say 1 to, what is it, 1 to 100?
1 to 1,000 or 1 to 10,000.
1 to 10,000.
Big difference. All right, spiders. You'll see this later. People will come to you and say, hey, I think I bit my spider. In this day and age of MRSA and skin abscesses, everybody thinks they're abscess to the spider. It's like, no, it's just MRSA. It's not a spider. The two main spiders we worry about in Oklahoma and really the United States are black widow and brown recluse. There's a brown widow, there's some other ones, but these are the two main spiders you'll see in Oklahoma. And really, you know, as the name says, brown recluse, they're usually in sheds, they're in old boxes. They don't come looking for you. Black widows don't come looking for you. They have to kind of be found, usually someone outside, working in the yard or something like that. So a black widow, I have a hard time saying this, ledrocticism, that's what it's termed. Outdoor activities, usually it's at a lower extremity. People may not even know they were bit. It's minimal pain. The systemic symptoms can start about 30 minutes to 2 hours after the bite. What they'll usually have is muscle pain, kind of like severe cramps, or in their back or stomach. They just feel like they're seizing up. It's usually very agonizing, and there's no reason for it. They don't fall, they're not dehydrated, all of a sudden they just have this intense pain. It's been confused with a surgical abdomen. The abdomen can get so tight and feel like someone has peritoneal signs. I have seen black widow this severe one time, and this person was in agony. She got a ton of benzos, morphine, and just kind of had to wait it out for about a day. Usually resolves in a day to 3 days. There can be this issue, like say you got bit on the leg, where you have diaphoresis just of that leg. So it's this kind of neurologic vagal type deal where that muscle group sweats. It's a very odd finding. It's almost pathognomonic for a black widow bite. That picture right there doesn't look real impressive, but the bites usually don't. So it has that central area where it's clear, and then the perimeter is red. These do not become necrotic. That's a big point, because as opposed to brown recluse, these do not become necrotic. They usually don't get infected. You know, presenting about a day after you bit, the classic, they'll have burning in the sole of their feet, and there's burning and sweating in their lower legs. A very bizarre presentation. I don't know if you'll ever see. With the severe back pain or severe belly pain, you just want to make sure you're not missing another diagnosis. So you want to make sure you're not missing acute abdomen or an MI or something else. Typically, though, they'll have extremity pain. The treatment, mild minimation, is wound care, pain medication, maybe benzos to help relax. If it's severe, you cannot control their pain, or the pain is in the belly, the chest, usually they'll require IV medications. Most of them have to be hospitalized because they need multiple doses. A long time ago, people thought to give calcium. They thought, oh, they're contracting all these muscles, it would help to give calcium. Doesn't help. There is an antivenom for black widow bites. It's in very short supply, it's very hard to get, and it itself has problems anytime you get an antivenom. It's only for very, very sick people that are not responding to your typical treatment. And the problem is that you can then induce anaphylaxis by antivenom that react to the actual antivenom. So brown recluse. This almost happens on a weekly basis. And someone thinks they've been bit by brown recluse because they saw something on the internet. Dr. Google is very helpful in scaring the snot out of people. What's going on? So, brown recluse or the fiddleback. Can you all identify brown recluse? Y'all see the fiddleback on their back. There's another spider, the wolf spider, kind of looks like it. They do not have fiddleback and they're a little furry. So the venom in a brown recluse is nasty. It is very nasty stuff. So phospholipase D is the most important one. So it chews up tissue. It causes necrosis. There is systemic symptoms because it activates complement, starts the inflammatory cascade. So you'll see down at the bottom, kind of the back of that guy's neck. So you see kind of that red plaque or papule. It almost looks like a bruise. It's kind of ecchymotic. It may be a little purple. The ones I've usually seen look a little purplish reddish. They can have like a middle picture, the vesiculation around the site. They'll actually get blisters around the periphery. And then it can develop this dark depressed center.
So it starts to get this F-scar, starts to get black. Depending on the degree of envenomation, it can expand quite rapidly over several days. Some people it does expand, some people it does not. So here's progression. So day 3, there's that guy's thumb. It's a little red. It's that purplish hue. So someone would come in and they'll say, I got bit by a spider, just red. And you're like, this is either a soft tissue infection or an early bite. Most likely it's not a bite, it's just red. It's when you develop that kind of purplish, like the back of that guy's neck. It has a distinct look to it as opposed to cellulitis. Day 3, it's a little purple. Day 4, it's expanding, it's starting to get a little more intense in color. Day 5, you start to see that necrosis, that little central area that's starting to break down. Day 6, you have dead tissue right there on the base of the thumb. And then between day 6 and day 9, he really, I don't know what happened. I don't know if he was seen or what, but basically he has lost all that tissue. And then day 10, he's probably had some debridement, and it is just, he had a huge envenomation, destroyed all that tissue, possibly down to the tendon, and is going to need a skin graft. So the ones I have seen, that time course, week or so, is about right, but you will see changes day to day. So in the ER setting, it's never wrong to tell someone to come back, no matter what you're treating. So a lot of times, you see them initially, it's just this little funny looking area. Hey, let's kind of treat it this way. We'll put you on this. And I'd like to see you back in 24 hours and seeing how it progresses. Cellulitis, abscesses, they may get a little red. They're not going to churn colors. They're not going to churn pallor. You're not going to have necrosis. You're not going to have the different findings like you see there. So that's the big differentiation between either a black widow or soft tissue infections. They have necrosis. So it gets in the necrotic. And that's because of the enzymes in the So the original papule develops dusky red, blue, purple, leads to this dry, depressed center. That center may be numb, can't really feel anything. Then that leads to an eschar, it's black, breaks down, forms a ulcer. A lot of times you also see it'll move due to gravity. I had a guy bit one time, older guy, he actually saw the spider bit him like on his belly. Here, see him, probably saw him 12 hours after he bit. Just kind of a red area. So okay, we just need to kind of watch you, come back in 24 hours. Then it was like this here. And it actually had gone down until it laid down toward gravity. And he ended up actually having an area of necrosis about this big. So this is sent to usually a general surgeon or plastic surgery or wound care, possible surgery. If they start developing, like that guy's thumb, extremities are very difficult. What you do, usually like at day 5 or day 6, and what happened probably after day 6 is they did an incision. So what you want to do is you want to get ahead of the venom. That venom, those enzymes are expanding out. So this guy, he started to expand, the general surgeon went in and just did a wide incision and took out his, kind of his skin and then did a skin graft. That's probably what happened between day 6 and day 9, is basically they went in and did a excision of all that tissue to hopefully decrease the spread of it. Because you can see after day 6, the margins don't really increase, even to day 10. It stays about that same area. So they probably went in and did a debridement to get rid of all the venom enzymes. It's rare that people get systemic findings, that they get sick and throw up and fever. The complications are mostly soft tissue, cosmetic, or functional. This is something I found because it is a big, you don't have to memorize all this. This is just kind of points that we've already made. Because so many people think they got bit by a brown recluse. This is what helps differentiate that. So recluse bites are typically single, not a whole bunch of little bites. That's usually like bed bugs. They typically occur in secluded locations, so attic, the garage, some storage area. The time of year too, November to March, much less likely. More people are outside summer. They usually have a pale center, like we said, turns necrotic. They're usually flat or sunken, but not some big blister. And lesions presenting longer than several weeks are unlikely to be recluse.
lesions greater than 10, unlikely. Ulcerates too early. Significant swelling is not typical, that's more infection. And okay, snakes, last thing. So, I hate snakes, I don't like snakes. I don't even like looking at pictures of snakes. So, these are the main, other than the coral snake, the other three are our main Oklahoma snakes. You'll probably see a snake bite. It's extremely common, more common than you think, even in homes. Up in Edmond, there's a large copperhead presence. There's actually several dens of copperheads. Okay. So we had a snake in our house, so the exterminator told me, yeah, they're everywhere. So sometimes they'll bring snakes in, want you to identify them. It's not typically recommended that you try to have someone get the snake, because then they're just going to have another victim, and it's usually not successful. But I would try to at least know what they look like. So a copperhead is pretty distinct. These are the pit vipers. They have a distinct head. They have diamond-shaped eyes. They have a very common shape of their eyes and their head. Copperhead has a pretty nice look to it. The cottonmouth, or the water moccasin, is the one they're just kind of black, but they're usually pretty thick. I didn't have the picture of its mouth open, but it's extremely white. And then, of course, a rattlesnake is pretty easy to identify. A coral snake, it's usually at the coast. We usually don't have them, but they are part of the pit viper family, and they're very venomous. And everyone has to learn the difference between a milk snake and a coral snake, because the colors. So if you remember red next to yellow, it kills the color. That's damage. The milk snake looks a lot like it, and if you see it, it's fine. It doesn't matter. Oh, 25% of bites are dry. Meaning, cross your fingers, if you got bit, you have a 25% chance that you get any venom. Envenomation syndrome. So you got bit by the snake. What happens? So initially there's just local tissue. So non-specific, it can kind of make you systemically ill, weak, have nausea, vomiting, sweaty. It's common to affect your coags. So coags are always checked. They can cause rhabdo. It's more not real likely. People can be hypotensive, tachycardic. It is, I've seen this, is the oral paresthesias. They'll describe either an unusual taste or tingling around their mouth. Rattlesnake usually causes more severe signs and symptoms than cottonmouth. Copperhead usually just local, limited symptoms. ID of the snake is often wrong or not available. So even though they didn't bring the snake, Joe Bob was like, I know it was a copperhead. That's what it is. And usually they don't. So you don't base your treatment on what they tell you. Base your treatment on what the patient's experiencing. So this is, I'm not going to go over this. This is probably the best algorithm to treat snake bites. This is an evidence-based algorithm. Two of the guys I trained with in North Carolina, actually, part of the team that made this. So, briefly, basically you assess the patient. You make sure they're out of danger. You update their tetanus. You get your initial lab studies. You treat pain. You look for signs of severe animation, whether that's abnormalities in the coags, your LFTs, anything like that, or their vitals. Indication for antivenom. I've given antivenom. The good thing now is about 15 years ago, a product came out called Crofab. So we used to give this horse antivenom, which was awful because it had a high rate of serum sickness and anaphylaxis. So Crofab came out, and it is to treat, and you don't even have to identify the snake. It's real easy. If they're a pit viper, they'll be treated by Crofab. So if they're starting to have some of these systemic symptoms, Crofab is given. Usually this is done in conjunction with a toxicologist. So you call your local poison control, talk to them about it, have your labs, and give Crofab. Crofab is expensive. It's come down in price. When it first came out, it was $5 to $10 grand. It's a couple grand now. But it binds the venom through an antibody, clears to the kidneys. It may take several doses because the venom will last longer than the Crofab. So
that unified algorithm is something I wouldn't necessarily memorize, just kind of know the generalizations of the labs you order, the signs you look for. Now these are the things you don't do. These are the things that, again, are urban legends. You know, I'm going to cut it and suck out the venom. Or, for a time, you know, those tasers, people used to tase. That's funny. It's just how to be mean to your friend. You're out camping, let me tase you. Don't do a tourniquet, don't do steroids. You don't have to give them antibiotics, it's not an infection. A lot of fasciotomies were done prophylactically, which is pretty mean. And NSAIDs are also to be avoided. So if someone gets bit, you want to try to immobilize the affected body part. If they got bit on the hand, remove jewelry, because they're going to swell immediately. Clean it, get them to the hospital. They say to transport to the hospital supine. They used to always say, oh, keep it below the heart so the venom won't get systemically. It usually doesn't matter. The handout is the treatment. Like I say, crow fab. It's purified fab fragments of sheep that were given to them. So it binds the venom, it's cleared through the kidneys, and like I said, you may have to multiple dose it, but usually this is always done in conjunction with a toxicologist at the poison control center. So they're extremely helpful. And in case you get a weird snake bite, like they come in and they're, do any of you keep snakes? My cousin does. She's crazy. She has lizards, she has monitors, she has snakes, she's crazy. But you'll find we had a person in Charlotte, and they had some puff adder, like this bizarre snake, and they had gotten bit. Well, what I learned through that experience is the best way to treat that person is call the zoo. If you call the zoo, they actually have some of these weird antivenoms. So it's just one thing to kind of remember, because God forbid someone gets bit by some crazy snake they're keeping, the zoo is actually a great resource for it. So that and your poison control center. Poison control is very helpful. Call them because a lot of their money and how they get funded is based on the call volume. So I try to call them just to help with numbers and get information. It's also good for documenting in the medical record that you pursued that to get as much information, whatever be exposed to the rest. So, one last thing, any questions?
How often do you see patients that don't respond to antivenom if they come in with a snake bite?
It's rare, especially now with ProFab. In the days of the horse antivenom, it was very common. And the bad thing was there was a pretty high rate of people getting serum sickness. And so it's always frustrating that the therapy can be as bad as the disease. And so, and then you don't know, is it progression of the disease or is it what we're doing? But ProFab has really changed everything. It's made it a lot easier. One last thing, like I said, drowning. So as healthcare professionals, I feel one of our responsibilities is public education, taking care of people. Especially in emergency medicine, we see a lot of the results of bad behavior or lack of self-responsibility. So infant swim resources is something that just keep in the back of your mind. If you have kids, you have relatives, you have cousins, nephews, whatever, but this is a easy training resource that's available actually in our city now. All three of my kids did it. My son was 17. When he did it, there was only one person in the state that did it. Now there's like 8. And so this is a video that shows you what it is.